question we have to answer. Urine glucose is negative. You can see what is the threshold for urine glucose? 180. So, you can see this patient has got a urine glucose of 186, but even then the urine glucose is nil. It signifies that in a diabetic subjects the threshold slightly goes up. You will find many patients having blood sugar level of 220, 230, 240, but the urine glucose is nil. In a normal subject it is 180. If I give lot of glucose intravenously, and if I can make your blood glucose level up more than 180 milligram per dl, then your urine will show positive glucose. But in a diabetic subject who are exposed chronically to the high blood glucose level, these tubular cells, they get adapted to the high blood glucose level and they reabsorb more glucose, and therefore the urine sugar becomes negative, even though the plasma glucose level is more than 180 milligram per dl. Yes. So, that is the idea to give this urine glucose. Now, therefore, if we look into the classification of the diabetes, there are 4. So, all of you are aware, one is type 1, another is type 2, another is gestational, and there is other specific types. So, in the type 1 is basically because of absolute deficiency of insulin, all of you are aware, but I must tell you that they have got 2 sub variety which you should learn now. One is insulin immune mediated, another is idiopathic. We do not know the cause why it happens. In our country particularly, we have slightly higher prevalence of non-immune mediated or idiopathic type 1 diabetes. So, this is we slightly differ from the western countries. So, in some of the type 1 diabetes, they behave like type 1 diabetes, they are ketosis prone, they have absolute insulin deficiency, they require insulin for their survival, but if we check the autoantibodies, they are sometimes negative. So, that we have to keep in mind that autoantibody negative does not guarantee you that the patient is not suffering from type 1 diabetes, and you cannot stamp a patient that the autoantibody negative and therefore this is type 2 diabetes and start treating the patient with oral anti-diabetic agent and you push the patient to a diabetic ketoacidosis. So, that is the thing. Second is type 2 diabetes, which is the most common variety. 90 to 95% of our population actually suffer from type 2 diabetes. Therefore, we actually more concerned about the type 2 diabetes. Actually, we will talk about the type 2 diabetes mellitus in the whole certificate course. Actually, basically we will talk about type 2 diabetes more than the type 1 diabetes, and they are basically because of either of insulin deficiency or because of insulin resistance. All of you are aware, initially it is the insulin resistance that is the more important. In the later part of the diabetic life, it is the insulin deficiency that becomes more and more important. So, the more and more beta cell get destroyed over decades, and therefore, initially there are insulin resistance by which actually the process of diabetes started, but once the few decades has passed, about 2 or 3 decades has passed, then the beta cell becomes exhausted, there is apoptosis of the beta cell and the patient becomes insulinopenic, and then it is the insulin deficiency that actually predominant than the insulin resistance as far as the development of hyperglycemic state is concerned. So, other specific types are not very important as far as you are concerned, because it is we do not see lot of other specific types, but among the other specific type I would like to mention about the pancreatic diabetes, and one group of the pancreatic diabetes which is basically we see in our country and also in some of the tropical countries, the FCPD, fibrocalculous pancreatic diabetes, and previously we used to call them malnutrition modified diabetes, malnutrition related diabetes or something. There are so many names of that. So, malnutrition related diabetes. So, malnutrition related diabetes has got two variety. One was fibrocalculus, another is non-fibrocalculus, non-calculus variety and calculus variety. There are two variety. Anyway, so it was actually under a separate heading in the classification of diabetes, but after that a few years back the AD has said no, everything should be under the one heading of other specific type. So, it is no longer enjoys its status as it was before. But anyway, we see these patients, they are other specific types and they have pancreatic calcification. Majority of the situation they are young, but they have insulin deficiency, they require the insulin as their treatment, they usually do not respond to oral antidiabetic agent, there is no insulin resistance quite naturally, and they usually do not develop ketosis. So, that is the point. So, though they are more or less like type 1, you can see that they are young, but they are not as young as type 1, but they have pancreatic diabetes, they are fibrocalculus disease in the pancreas, and therefore, there is insulin deficiency. They require insulin for the treatment in the majority of the situation, but they usually do not develop ketosis. That is the point. They are non-obese, lean. The majority of the patient have some malnutrition related symptom, the diarrhea and the fatty stool, steatorrhea. So, this is type 1 usually occurs between the 5 to 15 years of age, between 5 to 15, but type 1 can occur at any age. So, there is nothing like that if the patient has got an age of 17 and we will not diagnose the patient as type 1, or if the patient has got an age of 25, we will not diagnose the patient as type 1, but in the majority of the situation the type 1 present in between 5 to 15 years of age. In the majority of the situation type 2 presents 30 years above. So, it does not mean that a patient of 21, a subject of 21 cannot develop type 2 diabetes, but quite naturally if it is between 15 to 30, we have to think the possibility of both type 1 and type 2, because the patient may be on this side or that side. Endocrinopathies are very interesting aspect of the other specific types. As you know that there are 4 hormones which raises the blood sugar, and there is only one hormone which decreases the blood sugar, that is insulin. So, any of these 4 hormones, if any of these 4 hormones are excessively produced, say for example catecholamine in pheochromocytoma, okay. So, something like that, glucagonoma. So, any hormones, somatostatin will not cause, but the growth hormone producing tumors, say acromegaly, okay. So, Cushing's. So, these are the hormones which are responsible for raising the blood sugar. So, any tumor or any disease which produces excess amount of growth hormone or catecholamine or cortisol or glucagon will be associated with diabetes, but they will be considered under the heading of other specific types. We are mainly concerned about the primary diabetes, that is type 1 and type 2. I think gestational diabetes we will discuss in a separate module, so I am not going into that. In the young, we see apart from type 1 and type 2, we see another group of diabetes, that is MODY, maturity onset diabetes in the young. I do not think it is very important for this course, but you just have to, you must have some little idea about the MODY. What is that? Now, if you see that when the insulin secretion occurs, this insulin secretion from the beta cell, it is through a design process, and during this process there are many proteins and enzymes are involved. Okay. So, insulin secretion occurs when the